I hope you can hear me loud and clear. Welcome to today's webinar organized by SAIDS, or Southeast Asian Thoracic Society, on pleural physiology and chest drainage. I'm Dr. Agasthian, and I'm the moderator of this session, and which will be followed by Dr. Kan from Sarawak, who will be talking on the physiology of pleura, and then Mr. Tobias from Sinapi, who will be talking on his chest tubes. So I have no disclosures, and before I start, I'd just like to thank Sinapi for supporting this webinar. So just a few words from my own personal experience on pleural physiology and drainage. If you look at pleural physiology and chest drainage, chest tube and chest tube drainage system constitutes of two parts. One is the chest tube part, and the other one is the drainage system. And chest tube and drainage system has always been the Achilles heel of thoracic surgery. As you all know, that if you cannot remove the chest tube, the patient cannot leave the hospital. So it prolongs hospital stay. And if you cannot remove the chest tube and you do not have a proper drainage system, there's mobility, prolonged chest drainage, either due to air leak or prolonged pleural fluid. So if you look at this, this diagram, it shows very nicely how you can nowadays do a digital drainage system as well as putting pleural manometer. You can actually measure various pressures, pleural pressure as well as airway pressures in various scenarios like lobectomy, segmenectomy, and what happens to pleural pressure and pleural physiology during presence of air and presence of air leak, and when there's absence of air leak. So you can see it's very, very accurate nowadays. So it gives you very good accuracy. And why is this important? Because if you look at the evolution of chest tube drainage and chest tube management over the years, in the last 20, 30 years, it has completely changed. And it has affected our daily practice of chest tube management. And the benefits are that nowadays, you know that when I was a young surgeon, we used to release the inferior pulmonary ligament whenever you do upper lobectomy, thinking that this helps to cut down pleural space. But actually, that's not true anymore because most of us don't do this anymore. There's still no pleural space problem. And we used to do daily chest X-rays. Nowadays, we only do PRN chest X-rays. We used to use two chest tubes, one to the apex and one to the base. But nowadays, we have found that one chest tube suffices. And this is important because less chest tubes you use, the less pain the patient experiences. We thought that you have to use large bore French 28 chest tubes for drainage, unless it gets blocked. And that has been found that is not true anymore. We have all gone on to smaller bore chest tubes like French 20 and French 18. We also found that from pleural physiology, we found that what used to be the gold standard of pleural drainage, 2 to 3 mils per kg per day, is no more true. Nowadays, you can, in fact, a lot of surgeons remove chest tube irrespective of the drainage. But most of us follow the algorithm that when it's less than 400 mils a day or 300 millimeters a day, you can actually remove the chest tube. And it's been found that if the chest tube is less than 400 mils a day, 1 in 10 patients need to re-intervention. And if it's less than 300 mils a day, it's less than 1%. And also, pleural physiology is helped out in cases like cardiothorax. Cardiothorax, no matter how careful you are, you will find that in about 1 in 500 cases with cardiothorax. This is due to the physiological understanding of the anatomy of lymphatics, where in 1 in 500 cases, the direct mediastinal lymphatic drainage into the thoracic duct. And in 1 in 500 cases, not only is there direct lymphatic drainage into the thoracic duct, in these cases, there's absent effective lymphatic valves, which causes retrograde flow into the chest. That is why, no matter how good a surgeon you are and how meticulous you are, you will get once in a while cardiothorax, and this is due to physiological understanding of the anatomy of the pleural lymphatics. And then what else has changed? The other thing is whether you should put purse string or no purse string. Or if you put purse string, should you put non-absorbable or should you use absorbable, like the BARB switches? I think most of us still use purse string, but what we have done is we use absorbable purse string sutures where you don't have to remove the purse string in the outpatient setting. What about chest drainage itself? There's so many things to consider. What is whether you need to suction or no suction, whether you do wet suction or use dry suction, whether you use wall suction or portable suction. whether you should use ambulatory chest drainage. And that's what controversy is always, which is better? Analog chest drainage is better or digital is much better? So if you look at analog, you guys see the evolution of analog system. What used to be a warm water system has become a closed water system. Then it became three bottle system. The three bottle system consists of three parts. One is the drainage tube, one is the water seal, and the other thing is a suction bottle. And in modern analog system, you'll find that all these three things, chambers have been incorporated into one chest bottle system. Then we have the digital system, which is actually a smart system. It's like a smartphone. It allows you to have, it's a portable, it gives you portable continuous suction, it allows early ambulation. And of course, it gives you a continuous monitoring, gives you a continuous graph monitoring, which allows you to know what's happening in the last 24 hours. And here you can see what, and from the continuous monitoring, you can predict things like prolonged ALIC and prolonged drainage. So, however, digital system, the problem with digital system is cost. It's very costly. And it's difficult in third world countries or developing countries where the system itself addresses a lot more cost to the patient. Secondly, it needs to be charged just like any handphone and everything else. And like all electrical things, when the electrical part goes wrong, it's quite chaotic and dangerous to the patient. So, which brings us last to this very important topic. Yes, as there's been a lot of developments in the digital system, there's been a lot of developments to improve the analog chest drainage system itself. And this will be addressed in this talk, which will be the second part of this talk. So the first talk will be given by Dr. Kan, who is the Cardiothoracic Resident. I'm very happy that he's giving this talk. He's put in a lot of effort to prepare this on physiology of the pleura and chest drainage system. And this will be followed by Mr. Tobias, who will the developments in the analog system, in the Sinapi system. So I will first introduce Dr. Kan, who will start his talk, and then after that, Dr. Tobias will continue with it. And then last, we have the Q&A session. I hope you will all put in your questions in the Q&A systems, then I can address it to the respective speakers. So I will not be reintroducing Dr. Tobias. So after Dr. Kan speaks, Dr. Tobias will carry on. Dr. Kan, please carry on.
Thank you very much, Prof, for the kind introductions. May I share my screen? Yep. Okay. Very good evening to all. Thank you for the opportunity given to present on a SEEDS webinar today. My name is Kan. I'm a third-year cardiothoracic trainee in Sarawak Heart Centre, Malaysia. So today I'm going to talk about pleural physiology. Now, this topic is very important for us because as a thoracic surgeons, we are actively managing the patients with the post-operative thoracic surgery, and as well as patients with spontaneous and traumatic disruptions of the pleura. Now, the outline of my presentations today. So first of all, I will cover a little bit on the pleural anatomy and the histology of the pleura as well. Then subsequently, the gist of the presentation today is mainly on the pleural physiology. So in this topic, I'm going to talk about how pleural fluid is being produced, and also subsequently how the fluid is being drained, and how the balance of these productions and the drainage brings about the pleural liquid pressure. And also I will talk a little bit on the pathophysiology of pleural effusion formations. And at the end of the presentations, I will touch a bit on the pleural mechanics in a normal spontaneously breathing patients, as well as the patient with stable pneumothorax and active ALIC. Now this diagram shows a cross-sectional view of thoracic cavity cut at the level of pulmonary artery. As you can see, the pleura is actually a serous membrane that wraps around the lungs and also the adjoining structure. It consists of two layers: the visceral pleura, which covers on the surface of the lung, and the parietal pleura, which covers the costal surface of the chest wall, the mediastinal region, as well as the diaphragmatic regions at the bottom part of the cavity. So these two visceral and parietal pleura are actually meeting each other at the level of hilum. Now, mainly the functions of pleura is first to maintain the lungs fully expanded and opposed to the thoracic cavity. And second, it actually allows the reciprocal sliding movement of viscerals and parietal pleura on inspirations and expirations. Now, this is a schematic drawing of how a pleural space is. Now, a pleura consists of single layer mesothelial cells here, which lies on the sheet of loose connective tissues. These tissues consist of collagens, elastic fibers, or cells that with the characteristic of fibroblasts. You have capillaries and lymphatic vessels, and also nerve ending as well. Now, on the surface of this mesothelial cell, you can actually see a lot of microvilli. It helps surface area of the absorptions of the fluid. If you see very closely, there is invaginations of these structures on the parietal pleura, what we call a lymphatic stomata. Now, this lymphatic stomata is connected to the extensive network of submesothelial lymphatic lacuna, which are responsible for the drainage of pleural fluid. If you see very clearly in the diagram, the lymphatic vessels of the visceral pleura are actually not connected to the pleural space, and therefore visceral pleura is not involved in the drainage of the fluid. In terms of thickness, the visceral pleura has a thickness of about 100 micrometers, which is about 5 times much thicker compared to the parietal pleura, which is about 20 micrometers. And the pleural space itself have a diameter of about 10 micrometers. This diagram shows the transmissions electronic microscopic image of how a lymphatic stomata looks like. These stomata usually have a diameter of about 1 micrometers and actually can be as large as about 40 micrometers. In terms of density, on the costal surface, the parieta is actually much lesser. It has about 100 of them in 1 centimeter square area. But in contrast to the diaphragmatic surface, which is the most dependent part of your thoracic cavity, you have larger density of this stomata, as we know that it can conclude that the density itself reflects the amount of drainage occur, which means the diaphragmatic surface actually involves more in the drainage of the pleural fluid. Now, the parietal mesothelium and the mediastinal regions that contain this stomata, it is so rich that it even has its own name. This structure is known as cribriform membrane, or in another name, Kapmeier-Fourcade. Now, in between this visceral and parietal pleura, you have this pleural space. And this pleural space, in fact, is filled by a very thin film of serous liquid, what we call as pleural fluid. Now, this pleural fluid serves as a lubricating fluid that allows the visceral and the parietal pleura slide, rather than touching each other, it slides along each other, and it produces a very low coefficients of frictions. Now, how does this lubricating mechanisms happens? This lubricating mechanism is thought to be operated by these repulsive forces of charges that is carried by this phospholipid molecule. These phospholipid molecules are produced by mesothelial cells via the process of exocytosis. These phospholipid molecules contains hydrophobic tails, which carries the negative charges, and then it was distributed along the pleural surface. So imagine you have 2 negative charges, they are trying to repel each other. So the electrostatic repulsions that produced by this tail is the ones that produce the sliding movement. Therefore, in fact, in reality, these 2 membranes are not touching each other. They have a very low coefficients of friction, which is about 0.02 only. Now, after knowing how is the anatomy and histology of the pleural space, we talk about how the fluid is being produced by a mechanism called polarizations or filtrations. Pleural fluid itself has a very low concentrations of protein. It has about 1 to 1.5 grams per deciliter protein, mainly consists of albumin. The amount of fluid in a normal adult is generally about 0.3 milliliter per kilogram. As you can see from the diagram, in fact, the filtrations actually occur usually at the more subatmospheric pressure, which is the apical part of the thoracic cavity, and the less dependent area. The filtrations occur by the productions of the fluid through the flowing of the parietal pleural circulations. So once the pleural fluid is being produced, it is flowing down into the dependent area, and there is where the drainage occur. Now, as I mentioned, the fluid is being drained by the lymphatic in the most dependent regions, which is the lower part of the costal lymphatics, the diaphragmatic lymphatics, and the mediastinal lymphatics. Now, this lymphatics system is a very, very efficient, very good negative feedback mechanism, and it helps to regulate the pleural fluid dynamics. Say, for example, you have a 10 times increase in the filtrations of the fluid, for example, because of increase in the hydrostatic pressure, increase in the permeability due to inflammations. Now, studies have shown that because even though you have 10 times increase in filtrations, the amount of the pleural fluid at that particular of time will not be even doubled, because there is a concurrent increase in the rate of lymphatic drainage as well. Now, the reabsorption velocity is about 2 millimeters per minute, and it can increase up to 40 times to prevent fluid accumulations. Pleural fluid turnover is about 0.15 mils per kilogram per hour, and in every hour, the pleural fluid is being renewed. Now, as I mentioned, there is uneven distributions of these lymphatic stomata. You have a greater density of one area, which reflect a more effective draining capacity compared to the other. And the visceral pleural, as I mentioned, is excluded totally from a pleural fluid turnover because in the physiological conditions, because first, it is relatively thicker. Second, it has a lower permeability by almost 10-fold. And last, it has no stomata on the surface. Now, now we know how the fluid is being produced and being drained. So it is very important for us to know the mechanism of fluid movement is actually strictly follow this equation, this law. This is what we call as Starling equations. Now, from these Starling equations, it is the equation stated that how a fluid movement from a capillaries into the interstitial space. Pleural space is considered one of the interstitial space. Now, the capillary hydrostatic pressure and the interstitial osmotic pressures are the pressure that drive the fluid from the capillaries into the pleural space. On the other hand, the capillary osmotic pressure and the interstitial hydrostatic pressures are the pressure that push the fluid out of the pleural space into the capillaries. Now, there is additional factors that happens only in the pleural space, which is the lymphatic systems. It plays a fundamental role in the clearance of the pleural space as well. Okay, so now I'm going to talk on the concept of how we know about this pleural liquid pressure. Now, given in a gravitational field, given a container with a water column where the static fluid is static, which means there is no flow. In this container, every 1 centimeter going down from the zero, which is the surface, you will have increase in 1 centimeter H2O pressure. This is what we call as hydrostatic gradient. Now, one can easily say in reverse for a pleural cavity. Assuming the zero is where the drainage occurs, which is the most bottom part of the pleural cavity, and 35 centimeters is the average diameter, average length, or average height of the pleural cavity, pleural height in a normal adult. Now, if you follow strictly what hydrostatic gradient it is, every 1 centimeter increase in height should actually decrease the pressure by 1 centimeter H2O, which means at the top part of your cavity, pleural cavity, you should have negative 35 centimeter H2O pressure. However, this is just a model. Now, studies have shown that the average pressure at the top part of the apical part of the thoracic cavity is only ranging almost about negative 10 centimeter H2O. There are a lot of factors that affecting this. mainly the gravity as well as the intrapleural fluid circulations. Now, because of, pleural fluid liquid pressure, because of this balance between the productions and the drainage of this pleural fluid, that creates an ideal sub-atmospheric pressure at the top part of the thoracic cavity. Now, there is a model saying that the lung is thought to be hanging within the pleural space by the very negative pleural liquid pressure at the apical area. At the same time, it is deformed by its own weight at the bottom part of the cavity, much like a hanging coil that is being hung on the top part of the ceiling. Now, there are also some researchers propose that the alveolar distensions at a given height is actually corresponding to the value of pleural liquid pressure, which means that the apical part where you have more negative liquid pressure, your alveoli tend to be more distended compared to the bottom parts of the lungs. And there is also why most of the apical bullae or black happenings only at the apex part of the apical part of the thoracic cavity. Okay, now we got to know all the physiology of the fluid movements. Now, very easy. If there is a disturbance of the equilibrium that is being set in the normal physiology of the fluid movement, of course, there will be presence of pleural effusion. Now, the pathophysiology of pleural effusion it's said to be caused by two main factors. One is there is an increase in the systemic capillary pressure and increase in the hydrostatic pressure, as well as the capillary permeability, both parietal and the visceral pleura. And the other factors, of course, is the limitations of the drainage of lymphatic flow. Mainly, for example, in the patients with a malignancy, who tend to have a malignant effusion, secondary due to obstructions of the lymphatic drainage. Now, there are some interesting facts here I would like to share. In the patients with the left-sided heart failure, where because of hypoxia and also inflammatory state, your capillary permeability is increased. At the same time, because of the backload pressure, so the lungs is edematous. When the lung is edematous, the hydrostatic pressures is increased, and therefore it drives the fluid into the pleural space, and it produces a transudative types of a pleural effusion. That is for the left side heart failure. Now, interestingly, in the patients with the right-sided heart failure, they notice that the pleural effusion is rarely seen in the right-sided heart failure. Why? Because theoretically, if you have an increased pressure in the RA or the central venous pressure, say for example, by up to 20 millimeter mercury, even though there is an increase in the hydrostatic pressures from the parietal pleura because of the backflows into the intercostal vessels and capillaries, usually the increase in the productions of the fluid by the parietal pleura are usually compensated by the lymphatic drainage. So for a right-sided, usually the increase in amount of effusion are most of the time being compensated enough, adequately, and therefore pleural effusions are very rarely seen in the right-sided heart failure. Okay, now at the end of this is the end of the presentations. I will talk a little bit on the pleural mechanics. This is what we measure in the respiratory lab. Formal measurement of the pleural pressure, of course, is impossible. And what we can simulate is that we insert an esophageal balloon catheter into the distal 1/3 of the esophagus. And that pressure, it's an estimated pressure of a pleural pressure. And at the same time, the mouth will be connected to a pressure sensor, or in the intubated patients, the enterotracheal tube will be connected to the pressure sensor. There is your airway pressure. Important terms here is the transpulmonary pressure. Now, transpulmonary pressure is the difference between the airway pressure and the pleural pressure. This transpulmonary pressure is the pressure that drives the airflow into the thoracic cavity and therefore brings into your lung volumes. Okay, so this diagram shows the fluctuation and the cyclical variations of these parameters in inspiration and expirations. As I mentioned, transpulmonary pressure is a difference between airway pressure and the pleural pressure. So in an inspiration, where the pleural pressure is decreasing, your transpulmonary pressure is increasing, and therefore it drives the airflow into the thoracic and cavity, and therefore producing the tidal volume at the inspirations. This diagram shows a different pictures of the transpulmonary pressures and the pleural pressure in 3 different groups. First, in the spontaneously breathing patients. Second is the patients with the stable 20% pneumothorax, which is undrained, and the patients with the ongoing chest tube, ongoing air leak that treated with the chest tube. So as you can see, the pleural pressures, this is the normal diagram of how pleural pressure it is. Now with the presence of air in the pneumothorax, which is undrained, your pleural pressure is increased. And if a chest tube is inserted, your pleural pressure will be returned back to normal. Okay, now because of the relatively fixed airway pressure, the transpulmonary pressure is a complete mirror image of the pleural pressure. Okay, this is a diagram showing how a tidal volume and airflow change between an inspiration and aspirations. And a spontaneously breathing, this is how the shape of the tidal volume it is, and the airflow into the thoracic cavity. With the presence of undrained pneumothorax, definitely you have lower transpulmonary pressure, and therefore lower airflow into the thoracic cavity and lower tidal volumes of the lung. However, with treatment of chest tube, your tidal volume seems to be going back to normal. And in fact, because of the active air leak happenings, usually the tidal volume will not reach the baseline here. Okay, so same happening to the airflow. There is nothing, not really much different in terms of the airflow. So basically, this diagram shows that with the insertion of chest tube, you actually bring back the physiology, the pleural mechanics back to it, the normal patterns. Thank you very much for your attention. This is the end of my presentation.
Thank you very much, Dr. Kan, for a very, very informative and interesting presentation. Just want to switch on slide. Yeah, good evening, everybody. My name is Tobias Van Reenen. I do work for Sinapi Biomedical, just to disclose that. And today's presentation, I will talk from an engineering perspective and a design engineer's perspective. I did study mechanical engineering, and in Sinapi Biomedical, I help with the design of the products. The Sinapi chest drain education. Topics we will cover this evening: overall chest drain development, the problem with current chest drains, the Sinapi solution, the new analog solution, and your benefit. And we will touch quickly Sinapi analog versus digital systems. General chest drain development, it started earlier. Literature shows that in 1875, the earliest bottle was used in literature by Dr. Bulao, a single water system. Then we have a multi-chamber system. Earlier literature for a 3-bottle technology is around about 1967, early 1970s. We have the digital systems. Earlier literature shows about 2008 started to the chest drain field. And then the Sinapi chest drain was officially launched in 2009. Now, a lot of the attendees tonight use maybe the first underwater drain or single bottle, maybe 1, 2, or 3 bottles. A lot of you use a multi-chamber system, and a lot of you use probably a digital system, and a lot of you as well use the Sinapi chest drain. So you might be already familiar with the Sinapi analog product. The underwater drain or single water or a single chamber system development, it started with 1 bottle. As you all know, you would put the tube coming from the patient about 2 centimeters deep into the water. And then they realized that this was actually very, very ineffective in drainage, because as the liquid level increases in the chamber, the opening pressure increases. When I'm talking about opening pressure, it is the pressure that your chest needs to overcome to actually open the valve, the one-way valve or the water seal, to see bubbles. So at the start, It is an opening pressure of 2 centimeters of water pressure, but now as it fills up, it might become 10 centimeters of water pressure, which makes drainage a lot more ineffective. So you can imagine as well, if you put a straw into a glass of water, if it's only 2 centimeters deep and you blow through your mouth, you can easily generate bubbles. If it is 10 centimeters, it's more difficult for your mouth to generate the bubbles, to open the seal. And that is exactly the same with your chest. So then what they did was the 2-bottle system. They decided to keep the trap or the collection bottle separate from the seal bottle. So now as the bottle fills up, it does not have an effect on your opening pressure of your seal or your one-way valve. But this had a big disadvantage that it added, and that was they added a lot of dead space. So when I'm talking about dead space this evening, I'm talking about the space between the chest and the seal, the closed space. So they added this volume to the system, and this made drainage also ineffective if it's not connected to suction. So they had to add a 3rd bottle to regulate the suction and take the effect of dead space out. Obviously, this is not very portable or allow a patient to mobilize easy. Some doctors use maybe 1 bottle, 2 separate bottles as well, and even 3 separate bottles, but this is a very crude and difficult system to use for the patient, the nurses, the surgeons, everybody to have 3 bottles. So then this is where the multi-chamber system developed from. It's literally just the 3 bottles, your collection chamber, your seal chamber, and your suction regulation chamber into a box. And this is the 3 systems. You have your collection chamber, your seal chamber, and your suction regulation chamber. So the multi-chamber system did not really solve anything or add any innovation to the field of chest drainage. It's just the 3 bottles into a box. So the problem with underwater drain or single chamber systems and multi-chamber systems, with underwater drain, inefficient water seals. There's a lot of clinical studies that show mechanical flutter valves are more efficient in drainage than water seal systems. When I refer to clinical studies in this presentation and you're interested to know more, please contact me afterwards and I'm happy to send the clinical studies that I'm referring to. With a water seal system, obviously because it's inefficient, it prolongs the chest catheter insertion, which is a major problem. And also with the swinging of the water actually decreases the efficiency as well. And I'll explain a little bit later. With the underwater drain, it's difficult to mobilize. They have to keep it upright always and lower than the patient's chest. And it's difficult to get the patient to move around and get out of bed to walk. The bottles fall over from time to time, which obviously breaks the seal, and the air from the atmosphere returns to the chest and the lung might recollapse or infection risk might happen. So there's a few problems. Tube clamping is also required due to transport, or if you have to lift the bottle higher because the liquid and air can move back to the patient's chest, and it requires a lot of nursing time. With the multi-chamber systems, it's bulky and heavy, and it increased the dead space, like I said earlier, with about 2,000 to 2,500 milliliter, and for this reason, it should remain on wall suction at least for most of the time. So most of the underwater drain or the single bottle chamber system, the multi-chamber systems did not solve. So coming to the Scheffler valve, the heart of the Sinapi. The Scheffler valve is a mechanical one-way flutter valve designed and developed by Sinapi Biomedical. It drains both fluids and air. It fastly regenerates the negative intrapleural pressure, which is obviously a very, very big advantage and important. It's got a large diameter to drain blood clots and epihema effectively. It never blocks, and it works in any orientation. It is not dependent to keep the product upright. It works in any orientation, and for that as well, it facilitates and supports easy patient mobility. If we look at the Sinapi chest drain, if I highlight the Scheffler valve location, we place it right here. Before the Scheffler valve, we added a suction bulb which you can press, and it gives a little bit of manual suction and shows a little bit of indicator for air leak and negative intrapleural pressure that I will get to a bit later. After the Scheffler valve, we put the container, the drainage container, and that allowed us to put a drainage tap. So now as the container fills up, you can actually remove the contents without breaking the closed system and decreasing, obviously, infection risk to the patient. We've added a dry suction regulator that requires no water to work, so you can regulate the wall suction. We do have a bubbling chamber, an air leak chamber, where you can see bubbles if need to, but with this device, you don't need to see or look for bubbles. And I'll show you a bit later in today's presentation why. We've got a needle-free port in the container or at the tip of the tube where it connects to the chest tube, a high negativity vent, and a tube roller that I'll explain a bit later. It's a complete dry system, which means it requires no water to work or to function. So your benefits. The Sinapi chest drain supports enhanced recovery after surgery. ERAS. ERAS guidelines focuses on a lot of advantages, but two things that they say that's very important is early patient mobilization and shorter chest tube removal time. And the Sinapi chest drain supports both of them. The Sinapi chest drain has benefits to everyone, the patient, the doctor, the nurse, and hospital procurement. Product safety is a big advantage. Earlier patient mobilization, and in these advantages, I'll discuss it as well in the next few slides. It's earlier disconnection from wall suction due to the low dead space of the Sinapi chest drain. It's easier to use, simplicity and quick setup, informed decision-making, faster patient recovery, shorter chest drainage time compared to conventional water seal system, and cost saving, which is obviously leads to reduction in hospitalization time and less complications. Product safety. First thing with the design process, simplicity reduces mistakes. Can be mistakes from a healthcare worker, not on purpose, or mistakes from patients. The Sinapi chest drain safety also eliminates the risk of a tension pneumothorax because no tube clamping is required because there's no risk for air to move back. In this video, you can also see that you can orientate it freely, can be placed on the back on the bed without losing the seal, and you can hang it next to the bed again. It also maintains a closed system when full and emptying. And in the picture on the right, you can see a product in the operating theater that's on the patient leg. And this product in this orientation works completely. It's functional. Obviously, if it is lower than the chest, gravity has an effect on chest drainage. But in this, it was connected and it started to drain. You can see the blood in the catheters. So with this chest drain, you can use it in this orientation, and this makes the use of it very safe and easy to use for everybody involved. Earlier patient mobilization, which is obviously a big focus for enhanced recovery after surgery. It's compact and lightweight, which obviously allows for earlier patient mobilization. It does not need to be on suction all the time because of the low dead space. Free orientation facilitates patient repositioning, and patient mobility results in faster chest drainage. As you can see in the video, it's very easy to mobilize the patient, get the patient out the bed, and help them with their breathing, and facilitates shorter chest drainage time. Easier to use. It's a plug and drain product. It's quick and easy, simple setup. The only thing you need to do is to connect it to the catheter, and it works. No need to add any water or saline. Emptying the product without effort, maintaining the closed system. You don't have to clamp the tube and disconnect the product ever until obviously after removal of the chest catheter. But in this video, you can see you can easily drain it, maintaining the closed system of the patient. And monitoring and management requires little intervention. Because it is so easy to use, the Sinapi 100% supports and enables ambulatory care or outpatient care. Because of the recent, advanced thoracic procedures over the last couple of years, it is actually possible after some procedures to send patients home after 2 or 3 days. But in most cases, they stay and remain in hospital because of chest drains only. So we at Sinapi, we are safely recommending the Sinapi chest drain for ambulatory care or outpatient management. Cost saving, it's only one Sinapi chest drain per catheter. If it's full, you can drain it, so you maintain the product. You don't need a new product. It saves a lot of nursing time for management. It reduces the risk of human error, maybe patient error, and obviously less complication results of that. Reduced drainage time and length of hospital stay, which obviously saves cost and less space in medical waste containers. When we get to drainage efficiency, which is obviously a very important part of chest drainage, minimal dead space, the Sinapi chest drain compared to multi-chamber systems or a 2 or 3 bottle system. When I'm talking about dead space, like I said, it's just the space from between the chest and the seal or the valve. If you look at Sinapi, the volume is a lot less on the top than on the bottom, and this has an immense effect on drainage efficiency if not connected to suction. The dry seal system of the Sinapi chest drain, due to the Scheffler valve, results obviously in no retrograde flow or no water swinging. If we look at an underwater drain or any water seal systems, the multi-chamber systems as well, the swinging of the water actually is ineffective, because as the water moves up the tube, the air moves back to the chest until it builds up enough pressure to open the seal and bubbles will show. So this water seal systems are more or less 2 steps forward with drainage, 1 step back, where the Sinapi chest drain is 2 steps forward, 0 steps back. And the Sinapi chest drain has a low valve opening pressure and maintains it throughout the patient recovery. The opening pressure results ultimately to less than 1 centimeter of water pressure for the whole duration of patient recovery. Informed decision-making with some Sinapi gadgets, visual monitoring features, negative intrapleural pressure that I'll get to, air leak resolved, and some historic data in an analog system. Firstly is the Sinapi bulb. Because the bulb is located before the Scheffler valve, it is in the closed space, in the dead space connected to the patient chest. So when you press the bulb on the left-hand side and it expands, you know drainage is taking place. Air is being drained. On the right-hand side, when there's no drainage or no air taking place, or air drainage coming through, it remains depressed. So this is a very good sign. Firstly, it gives you a little bit of manual pressure. So it is draining, but there's no air being drained. Secondly, it shows some historic data, because if you come and you press the bulb, let's say at 12 o'clock, then at 12:30 you come back, it's still depressed, you know that there was no air drainage or no fluid drainage in the last 30 minutes, because only when fluid or air from the chest is drained that the bulb will expand. So it shows you a little bit of historic data. And it also shows you immediately that there's negative pressure in the pleural space. Only when it stays depressed that there's negative pressure. Fluids above the valve is another indicator that we've incorporated. As the picture on the right-hand side, you look for fluids greater than 2 centimeters above the Scheffler valve. Presence of fluids means that there's no air leak. So at this moment, looking at the picture, you can be 100% confident there's no air draining from the chest. And when there's no fluid, there was obviously air being drained. And this also gives some historic data for if you, and with the pressing of the bulb that stays depressed. But if you see the fluids accumulating above the Scheffler valve, let's say also at 12 o'clock and 12:20, it's still there and the bulb is also depressed, you can be confident that there wasn't any air drainage in the last 20 minutes. So why does fluid collect? above the valve. It's definitely not because it's blocked. It's a very good sign, and it means that no air leak and negative intrapleural pressure is obtained. For example, with the picture, if you put a straw into a glass of water and you put your thumb on your finger on the top and you lift it up, you can see that the fluid's maintained. And why? Because there's a suction force at your finger and also no air coming in from the top. And this is a very good sign to show that the patient is nearing the end of treatment or end of recovery. Sinapi high negativity event or tube roller. We have as well for instances where milking and tube stripping is required. We've incorporated a tube roller and a safe way to milk and strip. We've added a high negativity vent that opens up at a safe pressure and allows air in through a bacteria filter to make milking and stripping safe. We also have a needle-free port at the tip of the catheter where you can add medicine to the patient's chest or take a blood sample if required. Sinapi analog versus digital. We state Sinapi is better than digital systems. A few factors to think about: mobility. Sinapi is lighter and easier to mobilize a patient. Outpatient management. Sinapi is safer to send patients home with. Monitoring. Sinapi provides all the monitoring parameters like I showed earlier with the bulb and the fluids above the valve. You can see some historic data. Drainage efficiency. There's no conclusive evidence that a digital system is more effective than a conventional water seal system. Some clinical studies show a little more effective, and other clinicals show no real difference in drainage efficiency. But also that's with conventional water seal systems. There's no study that have done where it's a mechanical flutter valve like the Scheffler valve in the Sinapi chest drain and digital systems. The maintenance of digital systems are obviously a lot and very difficult, and the cost is not even comparable, the capital cost of the digital systems, but also the disposable cost. When the digital system becomes full, you have to replace the disposable, and which adds a lot of cost. So in this way, with the new technology of the Sinapi chest drain, it actually brings things back to simplicity and to analog digital chest or analog chest drain systems like the Sinapi chest drain. Just quickly, a product range. We have a product range as well, pediatric, adult. We've got 2,000 milliliter products with a dual inlet, which is not necessarily required because we have a drainage tap on our other systems. So you can use it for 2 or 3 or 3,000 milliliters. And we've got a small product for outpatient management as well, or for a pneumothorax or an air leak specifically. Thank you very much. Please feel free to visit our website for more information, www.sinapibiomedical.com, and please contact me directly to inquire in your country. And I'll also post my LinkedIn profile, and this is just a QR code that you can scan for LinkedIn profile. Thank you very, very much. And I think we'll go over to the questions now.
I'd like to thank both speakers for the excellent talk. Actually, learned a lot today. And both of you, Dr. Kang and Tobias, thank you so much for the talk. So now we'll take question and answer. I'll start with Dr. Kan first. Dr. Kan, there's a lot of people asking many questions, but I'd just like to summarize. They want to know what kind of pleural physiology changes takes place when you do procedures like decortication, pleurectomy, or pleural disease. I know that's a tough question, but I hope we can try best to answer that.
Thank you, Prof. I think, in my opinion, so whenever there's a disruptions of the pleural, either it's a visceral or parietal pleura, you sort of like create a pleural disease. So when you create a pleural disease, your lung is definitely your aim of the operation. For example, pleurectomy for pneumothorax, you actually wanted to create the effect of pleural disease. So therefore, the lung is definitely already opposed or stick to the chest wall. And of course, there won't be any physiological pleural space present anymore. And therefore, the whole process of productions and also the filtrations and the drainage will definitely be disturbed. That's my answer. Correct me if I'm wrong, Prof.
Oh, you're right. Thank you. Thank you so much. So this is for Mr. Tobias, I think somebody is asking, will suction pods still required in Sinapi chest drain since the valve do all the work?
Sorry, Prof. Agasthian, can you just repeat that?
Can I say that again? Okay. Why suction pod is still required in your chest drain since the one-way valve does most of the work, does all the work, in fact?
That's a very, very good question. And to be honest, in most cases, we actually advise that with the Sinapi chest drain and low dead space, it's actually not required to put external suction on. But what we've seen over the last couple of years, that after some surgeries or some thoracic surgeons or cardiac surgeons specifically, they do want some external suction, and that's the only reason we added the suction regulator for the client need and the doctor's need specifically. And after cardiac surgery, that they also use the Sinapi chest drain, then often they do want it maybe at 20 centimeters of external water suction. But Sinapi gravity drainage due to the Scheffler valve is an excellent way, specifically for thoracic surgery, to clear the air leak.
The second question is also addressed to you. How do we tell if the Sinapi chest tube is blocked?
That's also a very good question. The first thing that you'll do to know, if you press the bulb on the Sinapi chest drain, if it expands, it obviously means that it's not blocked, and the chest catheter. And also in our air leak chamber, in the bubbling chamber, you can see the movement of the air as it comes through the system from the chest. In instances, obviously, there are a chance with all chest drain systems that the chest catheters can block from time to time. And with that, it might be, the similar way that you will look for to see if the chest catheter is blocked or not in other systems, exactly the same. But with the Sinapi, with the suction bulb, it will show you easily if it's blocked or not. So specifically, when inserted, when you connect the Sinapi chest drain to the chest catheter and you press the bulb there, it should expand. It shouldn't stay depressed. If immediately when you connect it to the chest catheter and you press the bulb and it stays depressed, then you know there's problems at the tip of the catheter is blocked, or it's not in connection with the fluid or the air to drain.
So here's another technical question, engineering question. So if you have operated on both chests, can Sinapi be used to drain both sides of pleura using a Y connector? And what are the disadvantages from using more than one drain to Sinapi?
Yeah, that's also a very good question. So we advise to use a Sinapi chest drain, one per catheter, but in a lot of instances, due to the client needs or the doctor's needs, they maybe use one Sinapi chest drain with a Y connector to two catheters. But we suggest one per catheter, but you can use it with a Y connector. And the only thing with a Y connector would be a disadvantage, same with the other systems, is that it would be harder to manage the pressure differences, because in the two catheters, the pressure differences would be different. So the drainage efficiency for just having one to the chest drain would differ. But it is safe and it works completely. But we do advise it's better to have one system per catheter, but a lot of doctors uses the Y connector specifically.
So, Tobias, somebody asking a technical question again. What is the valve under the needle-free sampling pot? Can you explain that one more time?
Yeah, that's a very, very good question. So the valve under the needle-free port in the collection chamber, so after the Scheffler valve, we use that actually in areas where it is obviously registered for autotransfusion, in South Africa, where we are from. Autotransfusion is a very general practice, and they use it there to spike it with the blood filter or blood giving set, and they actually auto transfuse the blood back. In a lot of countries, it is not the protocol, as the blood needs to be washed with a cell saver, but in countries where it's registered and where it's allowed for giving auto or blood back in this way, that's what the port is being used for.
And so the other question is, do you have cases where you have to replace a Sinapi drain in a patient, and what are those cases? So I'll answer that question because in the last couple of years, I've switched to Sinapi because of the simplicity. The advantage of using the Sinapi drain is so that you don't have to replace it, because when the chest bottle gets full, you don't have to replace the chest bottle. You just turn the tap, then it drains. In fact, I don't even use the 1 liter bottle. I use the pediatric 400 mils. It's ideal for the nurses because they don't have to mark the level of drainage every day, like in the atrium or some other bottle. All they do in the early morning, they turn on the tap, the drain comes out, they measure it, they switch off the tap. The next day, they wait, then they open the tap again. So they don't have to be worried about which level it is. The second thing is the 400 mils is so light, the patient can walk around. And when it's time to send the patient home, I don't have to change to another portable tube. I just send them home with the Sinapi drain because it is a one-way valve. So most of my patients are on digital Topaz. So if I have to change, I have to change them to Sinapi and them home. See, so I hope that answers the question. So one more question from Mr. Tobias. What's the retention rate of clients, hospital using Sinapi Schaeffler system? How many clients continue to use it for a long time?
So that's also a very, very good question. And we've had clients for more than 12 years consistently. When they change to our products, we do not know of one case where they change back for the patients or for the hospital. So the retention rate is, I would say, just to be conservative, more than 95%, 95 to 99% of clients maintain because of the simplicity, the ease of use, the drainage efficiency, earlier patient mobilization, all the things that we've added to help to alleviate your work and help make your life better. And for this reason, we've seen that the clients do retain with our products.
So I think somebody may not have, because the internet connection was not very good. Somebody wants you to answer this question. Can you apply suction to the Sinapi drainage? So can you just say that one more time?
Yeah, you can apply the suction to the Sinapi chest drain. The Sinapi chest drain has also a suction regulator that's very visible and very easy to use. It's a dry system, and there you will regulate the wall suction or the external suction. So yes, you can place the Sinapi chest drain to wall suction, but gravity drainage, it works very efficiently. But yes, you can attach suction.
Then why is Sinapi? Is Sinapi only good for thoracic surgery? Is it good for cardiac surgery too?
It is good for any surgery that requires chest drains. We have a lot of cardiac surgeons around the world that uses the Sinapi chest drain in South Africa or in Europe or across the world. We have a large cardiac centers that use the Sinapi chest drain, and also with the tube roller and the high negativity vent in the Sinapi chest drain, it makes milking of the tube and tube stripping safer. And so it works perfectly for cardiac surgery as well.
So the other thing is people want to know what's the cost difference between Sinapi and other similar analog system.
That's also a very, very good question. And the cost of the Sinapi chest drain is very comparable to the cost of a multi-chamber system or a 3-bottle chamber system. It's very comparable to that, but it also saves a lot of cost. Like I said, because if the other system, if they become full, you have to replace it. There's nursing care time, there's, storage space, space in waste containers. It's a lot of cost with the other chest drains, where our cost is comparable to a multi-chamber system, but it saves the hospital on a global spectrum or a patient spectrum a lot of indirect costs as well.
So Tobias, are there any instructions if Sinapi is used for air evacuation or on flight?
That's also a very good question. We've actually had a good response from the emergency services, and specifically for air evacuation or for flight, where the Sinapi chest drain is completely safe to use in a helicopter or an airplane. And it's actually, I would say, we've had clients, I think it was in Switzerland, that they said that they do not want to go on the helicopter without a Sinapi chest drain because it is safe. You can orientate it freely, and with the Scheffler valve, the drainage still plays effectively even in the air. So we've had a good response from air evacuations or flight with the Sinapi chest drain.
So, Dr. Kan, do you suggest a negative suction for bronchopleural cases? There are two schools of thought. One says yes and one says no. So what is your own thoughts?
Yeah, that's a good question, Prof. In my opinion, I think if there's a presence of bronchopleural fistula, especially there is extensive air leak, by applying pressure, you sort of like, this is what we call as steal phenomenon, which means you're sort of like stealing the air from the patient's tidal volume. So in my opinion, I wouldn't put negative suctions in the patients with the confirmed case of a bronchopleural fistula.
So there's another question here, actually is addressed to me, but you can answer first. When you have a patient with spontaneous pneumothorax, 2 chest tubes, and the air leak is still present with partial expansion, can we apply negative suction? You can answer first.
Well, I think there's difficult situations. I think we really have to assess the patients. I had a little experience dealing with patients with active air leak. That I found out that in the presence of active air, especially those intubated patients, when you apply suction, you sort of like the ventilator will start beeping up because the tidal volume they achieve during the mechanical ventilations would definitely drop further. So my experience dealing with much smaller types of pneumothorax, probably yes, we will consider putting a negative pressure or wall suction pressure. But in the extensive air leak, I think I'm not too sure, Prof, whether it's really efficient or not.
I mean, this is a big problem when you're doing a lung volume reduction surgery. The lung is so emphysematous, you do a wedge and it leaks crazy. And this is extrapolating from lung volume reduction surgery. It goes back to Joe Cooper's days, and it works very well. Minimum or no, see, and just wait it out until the air leak stops. Because when you apply negative pressure to very thin parenchyma, lung expands it more. And you just sit tight. As far as the patient is not developing severe shortness of breath or subcutaneous emphysema, just keep low suction or no suction and just sit it out. Of course, if this doesn't work, means the hole is so big, so you probably have to bring the patient back and repeat the surgery. Mr. Tobias again, what's the minimal height of Sinapi for the efficient drainage by gravity?
That's also a good question. Effectively, once you connect it, it can be at the height of the chest and work 100% effectively. If it is higher than the chest, the air drainage will still be able to take place because of the pressure differences inside the chest and atmosphere. But we advise, obviously, gravity has effect. We know gravity is a very big consideration with designing the Sinapi chest drain. So we say, if it's any height lower than the chest, it is effective, and more effective, or not more effective, but it helps. So we say if the patient is walking, it can be just chest level or lower. And if the patient is in bed, hanging it next to the patient on the bedside level is perfectly. So there's no minimum or maximum height. It's just having it in line or lower than the chest is perfect. But there's no risk if it's higher that it will move back the fluids or the air back to the chest, and air drainage will still take place effectively.
Can Sinapi be reused and sterilized again in a poor country?
Yeah, the Sinapi chest drain is a single use. So no, it cannot be re-sterilized and reused in poor countries.
What about rapidly reaccumulating massive malignant pleural effusion? Is the Sinapi be suitable?
Yes, the Sinapi chest drain is 100% suitable for malignant pleural effusion, and it works very, very effectively as well. I'm not sure, Prof. Agasthian, if you've had experiences or your clinical opinion as well, but for malignant pleural effusion, the Sinapi chest drain works perfectly.
I think it's ideal because you can use the 1 or 2 liter bottle and it accumulates. You just turn the tap and it just drains the system. Rather than if you use a standard chest bottle, you have to change the whole system. So it's ideal for rapidly reaccumulating a massive pleural effusion. So a few more questions before we end it. Is Sinapi suitable for abdominal ascites, drainage, and GI surgery?
It's also a very good question. It's
Difficult question.
A little bit, yeah, a little bit different crowd, but you know, the Sinapi chest drain, it's a mechanical chest drain. It's a mechanical valve. It works drainage fluids or air from a closed space to and opens up to atmosphere. So, you know, with any area where there's ultimately drainage required with a one-way seal, you know, or other chest drain products are used to generate the suction from or to allow the drainage from the patient, the Sinapi can be used. But yeah, that's maybe a different. It is a different field, but like I said, the mechanics of the Sinapi chest drain, this is how it is, and the mechanics of that drainage is also ultimately the same. So yes.
Dr. Kang, I think somebody asked a question of after drainage and surgery for empyema, how does pleural physiology get affected?
So does it mean it's decortications or?
Yeah, I think so. I think there's a repeat question. So can you just quickly?
Basically, decortications is, as I mentioned, it does affect the, because it's literally removing the cortex, and also sometimes the visceral pleural is also being removed. So the thing is that most of the time when there is a intrathoracic surgery and when post-operatively you do have additions and your pleural space is most of the time will no longer be present. And if the pleural space is no longer present, then of course there won't be any, theoretically, there won't be any filtrations or drainage anymore. So most of the time post-operations, when the lung is strictly, stick to the chest wall, so you don't have this reciprocal sliding movement anymore in compared to the normal physiological pleura.
I think, Professor, you forgot to mention this in your talk, but somebody asked, what's the smallest chest tube size that can be connected to the Sinapi chest drainage?
The smallest chest tube size, we have obviously 3 different connectors. It's a small, medium, and large, and the small will take, you know, the pediatric sizes. We also have a connector that has a lure lock at the end, specifically for chest catheters that you need to add with lure lock connection. So for all, yeah, for functionalities of pediatric drains, you can attach it to the Sinapi.
So I'd just like to add on, every Sinapi test kit comes with the 3 sizes, so you can just pick and choose. So that makes it very easy for you. So one last question, I think, is Sinapi available in India? Or for that matter, how can they get this from you, Mr. Tobias?
Yes, the Sinapi chest drain is available in India. So you can either email me, I'll put my email just in the chat section, and we'll put you in contact with our local distributor, and the same with all countries attending to today. Please contact us and we'll put you in contact with our local provider, and we will make sure that you get to test the Sinapi chest drain and please give your clinical feedback as well on our system.
I think due to time constraints, I have to end here. And there's been a lot of requests to whether this thing is available, this talk is available on the website. Yes, it's available on the SEEDS. You can go to the SEEDS website and look for this recorded talk. So, and take your time and look at it. And I'd just like to end today's talk by thanking both Dr. Kan and Mr. Tobias for their outstanding talks and very information. I think all of us learned a lot, and we would like to thank both of them and end this talk. Thank you so much, Dr. Kan and Mr. Tobias. And all of you, thank you so much for today's talk. And if you have any questions, I think you can email Mr. Tobias. His email is on the chat session. And also you can email any questions to Dr. Kan. I think everybody wants your physiology slides. So I think they can contact them directly. Thank you so much, all of you, and have a nice day.
Thank you very much.